Ladies and gentlemen, welcome to yet another Cardiovascular Innovations webinar. And this one is on managing complex femoropopliteal and below-the-knee occlusive disease. We have a fantastic group of presenters and panelists, and many of you who are joining in are encouraged to chip in with your questions. Let me go through some of the required parts of this presentation, which is the CME information. As you know, the educational objectives are designed to encourage discussion and educate each one of us through our case examples and our technical skills in peripheral interventions for this evening. And it'll be fully case-based. The idea is to keep it very, very interactive. It is accredited through the CME solutions. And as I will share, it is allowed for 1 AMA credit. The faculty for today are myself, one of the moderators, along with Mehdi Shishehbor, who may jump in anytime. And I would like to take an extra minute to introduce Dr. Peter Monteleone, who is the director of the Ascension Cardiovascular Research Institute in Austin, Texas, at the Dell Medical School. His disclosures are displayed. Dr. Zachary Rosol, who is an interventional cardiologist and ardent peripheral interventionalist and operator in pulmonary embolism at Baylor Heart and Vascular Institute in Dallas, Texas. He is my colleague and partner. And Dr. Sanjum Sethi, who is filling in for Dr. Sahil Parikh, who is actually on an airplane. And he is the director of the Pulmonary Embolism Response Team at Columbia University, and they have also a very exciting case for us. So let's go into the next part. I think the commercial supporters of this program are Abbott Laboratories, Medtronic, and Shockwave Medical. Without their support, this would not be possible. So thank you to the sponsors. At the end of the webinar, here's a link for you to claim the CME credit. You can also visit the CV Innovations website or scan the QR code, and you can claim your CME through this mechanism. Last but not least, the upcoming CVI 2024 conference is going to be in Denver, Colorado, between July 18th and 20th. So please register, and if you have not done so, we have already received excited support from our registrants and participants and faculty. So looking forward to see you all in Denver very shortly. So let's kickstart this evening's case presentation by inviting Dr. Zachary Rosol from Baylor Heart and Vascular Hospital in Dallas. Zach, you can just share your screen, and Kelly, if you can log off end your presentation. I think, Zach, the floor is yours. I'll mute myself, and we'll kind of interject if we have follow-up questions. I invite my other participants and presenters to also chip in. I also will be monitoring the chat, so all the attendees feel free to chime into the chat and ask provocative questions. I will happy to floor them and pitch them up to Zach for response. So over to you, Zach.
Perfect. I appreciate the opportunity. Really excited to be a part of this panel tonight. So everybody can see my screen, right, Subhash?
Absolutely. It's coming out clear.
You can hear me? Great. Okay, so we'll get started. As Subhash said, I am fortunate to be his partner, and so I wanted to share a couple of cases from our labs. I'm going to focus on SFA occlusive disease and some of our crossing strategies that we use. Hopefully you can take something from here back to your home and cases to do them more safely. So without further ado, there's my disclosures. So let's talk about this first case. So this is a 68-year-old female. Her past medical history is listed here, pretty typical for what we see for significant PAD patients, right? Significant tobacco use history, has coronary disease as well, has a normal LV function, was found to have an occluded SFA with monophasic flow below the knee on a duplex ultrasound, who has failed conservative therapy with cilostazol and a walking program. So she's here for endovascular, at least assessment, potentially intervention. So let's look at her first diagnostic films here. So here, I'll just let these play in segments. Let's make sure they all play here. There we go. So you can see a long segment here, SFA occlusion in the proximal portion, not uncommonly returns in the distal SFA to P1 segment as it enters the canal. And we have good 3-vessel runoff down to the foot with rather healthy PT and AT with an intact pedal arch. So to look at a slightly closer image of this, here's a zoomed in picture of that proximal cap, very ambiguous, okay? So anything here, unless you want to take a dissection reentry strategy, is going to want to bias down into that collateral vessel there, and it's going to be really hard probably to stay true lumen. Our approach has been to try to stay true lumen as much as possible. You can always make a hole larger. It's tough to make anything smaller. So in this case, we felt, given the health of the tibial vessels, it was reasonable to take a retrograde approach first. So we get posterior tibial access preferentially. Once we do that, we use a 4-5 radial slender sheath, and then we use a regular cocktail, for those who aren't familiar with that, from a radial operator in the coronary space. That's usually verapamil and or nitroglycerin. So we give that, and we take an angiogram to make sure that we don't see any other significant issues. And once we do, here's the distal cap. Okay, so we bring a microcatheter up. Our catheter of preference is usually using a 0.035 Navicross. And then we like to start with an 014 wire. So we use an 014 wire, starting with a command, and then escalate up into an Astato 20 usually. If we need, we can use 018 wires as well, but almost always we're able to navigate through that. And by doing so, we keep that track very small, whether we're subintimal or hopefully true lumen. And this is just a little example of the techniques here. So we just slowly moving the wire back and forth, a 1 or 2 millimeter bend, and we keep advancing that, trying to stay within the center of the architecture of the vessel the best we can. We leave the wire proximally to give us a good marker. Cannot quite penetrate that proximal cap, so we did bring in a Stato 20 wire with another microcatheter down just inside the proximal cap. And you can see here in the far right screen, we're using wires and we're looking to have them cross. Really important as well, and I'll demonstrate that in the next case, using orthogonal views as much as possible. So it's very common, we're flipping the catheter or the camera back and forth to see where those wires cross so we can approximate them to our best of our ability. Once we do that, then we're able to advance the wire inside the other microcatheter, and we now have a rail all the way through. We then bring our 035 Navi cross down if we can and advance that from above. In doing so, we then have access to give a very, to bring a supercore wire, another very supportive wire to deliver any type of therapy we may need. So we pre-dilate with this one with an undersized balloon. We were happy with the way that looked, and as a result, we went right in with a drug-coated balloon. And here's our final result here on this case. Great TIMI 3 flow. You can see the collateral vessels are now filling retrograde, which is what we want. No obvious flow limiting dissection, so we decided not to use any scaffold in this case. Another, just to articulate what I was talking about, we try to do the least amount of damage possible to the vessel, okay? So we don't use very many wires. That's the 4 or 5 wires that we use listed right there. And I would even say the command ES 018 is not one that we commonly use. So we start with a command wire, we move up to an Astato 20, we then move to an Astato 30, and if we absolutely have to, we then will use a glide advantage wire. But this is almost always starting with an 035 Navicross, which just allows for that wireless escalation if we can. The other nice part about using the 035 is if you're having difficulty advancing it, you can use a 90 centimeter 035 Navicross and place an 018 or an 014 microcatheter through that, and you're just providing additional support then for crossing. When we do have an ambiguous cap, if we're able to, we try to go retrograde as well, just because that distal cap is sometimes softer and more favorable to penetrate into the true lumen. My favorite sheath to use is a 4-5 radial slender, as I said. If the tibial vessels are rather diseased though, then we just go right with the microcatheter, and I'll show you that here in this next case. So this next case is a 65-year-old woman with coronary disease, prior interventions, former tobacco, COPD, and has a known right SFA occlusion on duplex ultrasound. She's failed an at-home walking program as well. You can see some of her labs and her medical management listed below. Here's her diagnostic angiograms. Again, we have a rather ambiguous proximal cap, okay, with return of flow in the distal SFA to proximal popliteal segment. And on the right, sorry, the picture's not perfect, but you get a sense that her tibial vessels are not quite as healthy as we showed on that last case. So even though the proximal cap was a bit ambiguous on this one, we felt like we wanted to try an antegrade approach first because of the health of the tibial vessels. So we move forward with that. Let's see if this will play here. So diagnostic on the left, slowly advancing an 01. This is an 014 command ES. You can see it moves freely, so we feel good that we're likely true lumen and not extra plaque here. And we get close to the distal cap. Cannot penetrate that with an Astato 20 wire either. So we're looking, these are two images in different orthogonal views. You can see the image on the left, it looks like we're very close to the proximal cap. But when you take an orthogonal view, we're probably a few millimeters away. And with trying different wires, trying different paths, we were unable to penetrate that. So as a result, we did decide to get retrograde access. And in this case, because of the health of that vessel, we just went straight in with our 018 Navicross wire and a command ES wire. So here you can see we're able to bring those wires close together, and you can see we're starting to interact with that with the antegrade catheter. And in the middle screen, again, moving between two orthogonal views, we were finally able to advance that wire inside the catheter. And then once we have that wire up and in the catheter, we then can bring the 018 microcatheter right into the 035. And now we have a very supportive rail to advance catheters antegrade. So we bring the 035 catheter down, we dilate. Oops, let me go back here. Sorry about that. We dilate. We did have a flow limiting dissection. Oh man. So we did end up using scaffold on this one, and here's our final result. As you can see, we were intraluminal and extra plaque at some point in time in the dreaded little spiral dissection there, but that's what the reason why we use scaffolding at that point in time. So again, you can always make the space bigger. You can't make it smaller. So we start with 014 and work our way up from there. Subhash, I'm going to stop there. Do you want me to share that third case slightly different, or save that for when we get back?
No, I think let me ask you a few questions, because I think there are some pointers here, and we have a few more minutes. You can maybe show the next case too. But
sure.
In the first case, and Peter and Sanjot, I invite you to chip in. So this initial idea of always going with a lower profile guide wire, this is something that we have started doing. And I think that the principle that the way we cross profoundly affects the definitive treatment is very important to highlight. You know, there is a way you can always get into and cross a CTO, but the way you cross it, you know, will depend if you end up laying down a lot of scaffold or not. And I think that the other aspect of these cases are that, and this is my view, and I and Zach kind of think it over and tell us if we are right, that we don't want to extend the antegrade or the retrograde approach to a point where we have to stent across a no stent zone. If you notice in this first case, Zach came up with a retrograde access towards the mid SFA and did not really advance the proximal catheter. In the first case, when he went antegrade, and he didn't really maneuver too much when he was unable to get into the distal cap, because if he would have created a loop or a dissection flap, he would be in the no stent zone near the Hunter's canal. So I think we call it the platforming phase of the CTO recanalization or the rendezvous. So the place where the rendezvous occurs is very important. And the third part is that if you're using two guide wires, if you have a ruler and you can show overlap of the two guide wires that Zach emphasized, you can pretty much get the point along the ruler where you're going to have the maximum chance of recapturing the antegrade or the retrograde guide wires. So I think, and I think what we probably Zach didn't show, he avidly IVUSes these. So we kind of routinely IVUS this. We do a quick, Phillips IVUS pullback just to make sure we have not created a big dissection flap. So Zach, did I capture your points? And then over to Sanjot and Peter for some additional comments.
Yeah, I think that's really, the IVUS point is important, especially to understand if you're true lumen or not. I'm a bigger believer probably in plaque modification than Subhash has been, especially with directional atherectomy. And you can do that if you're in the subintimal space for a short period of time. But if you have an extensive path where you have been extra plaque, you don't want to, you're going to create an AV fistula, or you could lead to a perforation, and then you're committed to only one therapy process. So it's really important on some of these cases that are long and you're not sure, running the Phillips IVUS down there to get an appropriately sized vessel, and also understand what your options are for plaque modification or degree of calcium to potentially predict a dissection happening is important. And I think we IVUS routinely because we all use self-expanding stents in these areas. And the minute you put a self-expanding stent in, you have committed that patient to that size of a stent. And we know undersized stents lead to restenosis and occlusion, and there's nothing else you can do about it when you have an undersized stent in that place. And so I do the patient a favor and choose the appropriately sized stent by running a quick IVUS all the way down and through the vessel.
Peter and Sanjot, any comments? Anything that?
Yeah, I mean, these are two really great cases. So thanks for sharing. My question is, so we've seen our practice pattern change, and I'm curious what your thoughts are. 5 years ago, I think we would have been much more likely to have dissected reentry and then used an Outback or a Pioneer. And
Yeah.
we also have moved more towards doing tibial access earlier, especially if there's a pain runoff. So can you tell me how your decision making? Because in the second case, you could have argued to have, because you were right by the proximal cap,
Right.
to use the reentry device at that stage as opposed to getting retrograde access, especially with the diseased tibial. So can you explain your decision making and how you approach it now?
Yeah, no, if we're there for a claudicant and we feel like they have adequate tibial vessels, so anterior tibial and posterior tibial, we don't really include the perineal on that. I don't have a lot of hesitancy to get retrograde access. I think a 4 or 5 slender sheath is so atraumatic, or if not, you can just use the microcatheter, especially if you're using an 018 microcatheter. And then you're just going to use, you're going to hold pressure for 5 minutes with your finger on the end of it. That's going to stay open. On the second case, you're right, we were close. I felt like we were true lumen all the way, and you're right, the IVUS would have shown us that with a Pioneer, but with the way the wire behaved, I felt like we could connect and that her vessels were healthy enough at that point in time. I didn't show our zoom. We did take a closer zoomed in foot shot that showed that we felt like it was adequate to stick that vessel. And on ultrasound, there wasn't circumferential calcium in the access area, so that also made it feel like we were safer to access that point. The hostile calcium, I will say, when you throw the ultrasound probe on and you can just see the shadow all the way down, and it's a 360-degree calcium, you know that you're gonna need 3 needles to pin the vessel, the tibial vessel in one place and trying to stick it. Those are ones that I would probably spend a little bit more time or bring a device from above at that point.
Yeah. Go ahead, Peter.
I was going to say that the two additions, so we talked about IVUS a little bit, which really has been game changing for crossing, these things, even as mentioned for sizing vessels, for decision about plaque modification. But there's something beautiful about 30 centimeters of an SFA CTO. You're coming from above, you're coming from below, and you could really pick your reentry site with intravascular ultrasound. The opportunity to do rendezvous, to do verse cart, to do whatever you're doing inside of the true lumen guided by IVUS. And I will say, now that I use that quite a bit, whenever I'm having any complexity kind of crossing an SFA CTO, it's oftentimes not the area where you think you're going to connect above and below, where you end up making that decision to connect. You might end up extending antegrade, being true lumen further than you thought you were, or coming retrograde more than you think you would to actually do that balloon angioplasty, cross into a lumen, and then do your dedicated treatment. The other thing that I'll ask, and these are both great cases, for me and for us, we're doing a lot more kind of retrograde distal SFA frog-legged access in these.
Interesting.
Being, go get your CTO, go a couple centimeters distal to your CTO reconstitution, frog leg the SFA and stick the SFA, with the thought being you're entering into a vessel that's severely diseased and oftentimes has collaterals bypassing it, as opposed to coming up from a tibial. And there's certainly nothing wrong with coming up tibials by any means. And in other situations, we'll use that, especially if that SFA CTO is extending into the popliteal. But how do you guys use much retrograde SFA access?
Actually, I used to do that more at the VA, but I have literally, not done one in a long time. The reason for that is that, pedal access and PT access or DP access, are so mainstream now. So I would love to see. So I think, Zach, if you don't mind, we'll move on to Peter's case and then come back to you if
Great.
remaining time remaining. So, Peter, over to you and to show. And we are kind of agreeing too much today. We need to spice it up and disagree, and let's make Peter our case example of.
I love it. I love it. I wish I had a distal SFA stick so we could argue about it as we were going. But let's dive in. This is actually a tibial case, which I think will be a lot of fun. Can you guys see just my slides, or do you see my notes as well?
No, your slides.
Perfect. So let's dive in. So this is a 68-year-old gentleman, typical risk factors, hypertension, hyperlipidemia, bad diabetes, and has a very plantar heel ulceration. That's been getting worse and worse and worse. Has an excellent wound care and podiatry team, had actually been seeing our orthopedics foot and ankle team, and there were just these ongoing concerns about, despite optimized care, he wasn't healing. And so typical axis, typical up and over, typical patency of the inflow vessels. We get down to the tibial vessels, we can see a bit of a diseased AT that becomes somewhat diminutive as it comes down. There's antegrade PT filling. And then as we're looking at kind of an off lateral view, we start to see that right at the level of the heel, that posterior tibial just stops. And effectively, this individual has kind of a large perineal. The perineal is feeding the entire pedal arch. The AT kind of peters out, whether that's congenitally or whether that's disease, but really that perineal is kind of providing straight line flow to the foot. However, the heel, where that half a year old wound has been progressing terribly, just is completely occluded distally. And we can see a small proximal cap. It doesn't look oblique. We see it kind of tapering into a small vessel. We see a tapering reconstitution. And the goal is to connect the dots in order to try to provide some wound blush to the one portion of the foot that's not getting blood flow. So similar, we use a lot of roadmap, a lot of digital subtraction angiography to try and optimize contrast utilization and work below knee. And so our typical algorithm is we have a 6 French sheath that's up and over down to the mid to distal SFA. We use 014 nitrix wires through 018 Trailblazer microcatheters, kind of workhorse wires getting us down into the posterior tibial. DSA lets us select the posterior tibial, and the plan is to try antegrade wire escalation and then think about what our other options are. On the first image, you can see the nitrix kind of brought down into the distal PT. You can see that nitrix wanted nothing to do with that proximal cap, so it's certainly flush occluded. On those angiograms, there was a thought, well, is there something of a micro channel that's going on there that we were potentially able to enter? We grabbed a tapered tip fielder XT, which is usual in our algorithm. It actually traversed quite smoothly. We tracked it with that 018 microcatheter, but we weren't re-entering. So you can see where those medial and lateral plantars are reconstituting off the distal PT, and we missed it. So we were certainly unsuccessful. Despite the wires moving quickly, they were not moving into the right place. And so we take a picture from above. We actually pulled the microcatheter back when we realized we're false. We take our picture and we've created what's at best a flap, what's at worst maybe some small kind of AV fistula down in that territory. We certainly weren't going to be able to cross this. We couldn't convince ourselves, well, that perineal is collateralizing the foot because this thing has been there now for 6 months. And so our goal was to cross this short segment, but very distal posterior tibial. And the question was how we're going to do that. So we convert to retro. As mentioned, retrograde techniques, retrograde tibiopedal techniques are very broadly accepted and widely used. Really, you can argue that you should not be a CLTI operator unless you have the ability to do these and do these well. But the further you go down into the foot, oftentimes the more complicated these things become to be. And so first we look at this and decide, well, do you want to try to stick into the actual plantar and give yourself some running room? Do you want to try to be perfect and get into that 1 centimeter of reconstitution? And then that raises the question of, well, that's a very short distance to traverse retrograde, and we'll actually be treating that entire segment. That's indeed what we tried to do. And so why did we try to be perfect? Well, 1, we saw it was open on roadmap. 2, by ultrasound, that was really the only area where we had a good opportunity to see that vessel. The plantar vessels were just tough and obscured and tortuous and quite complicated. And so our goal is to get as distal, but into that little 1 centimeter of plantar as we possibly could be. And so we worked for that. And in our mind was this concept that our wire would be crossing the CTO really upon access. And any sheath that we put in would also likely be crossing that CTO upon access. And so we'd have to be working very, very close to our sheath. So with the help of roadmap and ultrasound, we were able to, you can see, stick very down distal into the foot. Similar to the cases that were presented, we brought a 4 and 5 slender into the vessel. The reason why we brought a 4 and 5 cylinder we'll talk about, and it's because the thought being that we'd be introducing devices from below and potentially from above, concerned that if we just truly reversed our wire and flipped our wire out of our sheath, we're really right just beyond the exit of that CTO where we'd have to do some work. So we crossed with a V18. This is another important consideration. Depending on the access kit that you use for your retrograde crossing, if your crossing wire is in fact going to be navigating that CTO, some don't like that bare metal steel short micropuncture wire. So we engaged with that micro short catheter from that kit and then crossed directly with a nitinol V18 wire. We made sure we were true. We made sure our wire tip was free, and then we got our slender sheath into place. And then the question became, now what? Because our wire was across, our CTO, probably our whole sheath is across the CTO. And so we had to make some decisions about how we were going to find this and how we were going to treat. We started treating from below. So we treated the diseased portion of the distal vessel. The plan was to open the path from below and then navigate our antegrade wire back down into the plantar vessels. So we swapped for an 014 wire to let us use just some small, easily crossable coronary balloons, used a 2.5 by 20 coronary balloon up from the foot. And then we steadily backed our sheath out as we were bringing our balloon closer and closer and closer to our arteriotomy to attempt to open up an access path. And you can see that here, we're kind of pulling back the sheath, maintaining our wire position, so we still have that maintained, and then doing our angioplasty kind of coming down to the level of the foot. And then we brought a wire from above. So we maintained our wire from below. We brought our wire from above, and that wire from above is attempting to find its way either into the plantar or into the sheath. And it would have been easy if it found its way into the plantar, but in fact, it finds its way into the sheath. Wires tend to like wires, and you can see it. It's about to grab it, and there it is. So now we have kind of an externalized antegrade wire, which isn't particularly what we want. What we want is our wire going down into the plantar, so we can treat all the way into the foot and all the way into the arch. And so then it became this same process of pulling the antegrade wire back while pulling our retro crossing sheath back, slowly, and looking for the place where our actual arteriotomy occurred. And you can see we're actually holding pressure on our sheath as we're trying to antegrade cross our wire down and in. And thankfully, we were able to do it. And so we had to effectively get our sheath completely down and out of the foot. We pulled it at that point, got our wire down into the plantar, tracked that with that 018 microcatheter, and then we confirmed. We brought our Trailblazer down. We took a quick picture in the plantar. That told us that we were, in fact, where we wanted to be. We were able to leave a wire there, and we were able to do treatment. Now, one key is we left that wire actually up from below, with the thought being, until we knew for sure that we had confirmed that that wire was actually down into the plantar, we didn't want to give up that crossing path. All those steps of ballooning from below and ballooning our way from above and trying to select, we didn't want to shut down a path and be lost starting all over again. So not until we had that confirmation did we actually take that retrograde wire out, do our prolonged inflation with a 2040 nanocross across our arteriotomy, and then we had successfully kind of recanalized all the way down and into the foot. And so we had a PT that was completely open into the plantar. We have a much more robust filling of the inflow of the posterior tibial now because it's not all flow coming through the perineal. And we had a kind of a very nice result in this 3 centimeter segment of CTO directly overlying the actual wound. And so the conclusions from this case, this is a tough distal retrograde tibial case. And so retrograde crossing, of course, remains mandatory. The location for retrograde crossing is always important. We're always balancing this concept of, well, the further down we are, the lower our chances of causing issues, including compartment syndrome in the calf. But also sometimes as we get further and further even into the foot, that access becomes a little more complicated. It also raises this concept of the case does not end when you cross retrograde. So oftentimes the decision is how to treat, how to rewire, how to gain full access into the vessel and beyond our arteriotomy itself. And then this final question of recrossing the arteriotomy site can pose unique challenges, which this case really raised. So I'd be curious if folks would have addressed this differently.
Peter, an obvious question, I kind of know the answer, but I want you to articulate it. Is that in the absence of an AT and a robust perineal, there could have been another approach, is to come through the perineal and come transcollateral. And I'm sure there are good reasons for you to not do it. But did you consider it? And in a way, technically, that might have been slightly more feasible because you had a very, very well-developed lateral at the risk of some injury to the perineal and to the pedal arch, both minor and major. So your thoughts?
Absolutely fantastic question. So I get a little anxious about transcollateral crossing when that collateral is really the only runoff to the foot. And so in that there was no AT and everything was coming off the perineal, I'm always hesitant to try to navigate retrograde. And this is actually, though tortuous, not the most tortuous collateral. Now looking to the cap, I don't know, can you guys see my mouse running?
Yeah.
Maybe not. You potentially work your way all the way down to round and back. And the concern was just that perineal was the only runoff to the foot with an absent AT. I'd be more likely to try it if I had an AT that was open and a perineal collateralizing the posterior tibial, but it was staring me in the face and I was really thinking about it.
That is actually very cool. I have actually never accessed a plantar in that position, but I've never. This is very skillfully done, and hats off. This is amazingly well done. Any comments others than Zach and Samjeet?
Really interesting. I too have not accessed anything that distal. I think another point of that collateral is, it's tempting obviously to use the more proximal one, and while it connects, you have to think about having enough run-in to be able to deliver equipment and change your wire to something more aggressive. If you use the proximal collateral, which would be the larger one, it's very tortuous and connects right at the distal cap. So if you're going to try that, that's actually not going to be very successful. And I think your risk of damaging and having larger consequences are higher there if you are going to do that, is the point. And so I guess my question was going to be, did it visually connect, or was it going to be something that you were going to be feeling around for, like you were floating the septal collaterals in a coronary CTO?
It's a great question. So the proximal one, it reconstituted that distal posterior tibial exactly as you were saying, right above the occlusion, and at something of a 90-degree, if not worse, angle. So
yeah, right above your red arrow there for
right
everybody to see that.
So
that's not going to be successful.
And so, if you and sometimes within the foot and within the pedal arch, you'll see these little micro channels that you can potentially navigate on that distal collateral. And they were there. You can see the area where they're not quite connected there.
Right.
But I think we probably could have run, a taper tip wire down there. And the reason why I tried to avoid it was just because of that single vessel runoff with that kind of congenitally small AT. But if things hadn't turned out great, I would have wished I took the collateral.
The other question, are you a DVA site?
So great question. So yes, so yes, we are. And so that's always on the roster. It's interesting to think about DVA in this situation where most of the foot is perfused, but the wound is not perfused. And so that raises an interesting question. What do you think about that?
I guess you usually see it.
Yeah,
go ahead, Subhash.
This patient may not be a great candidate for DVA because he's got good pedal arch. I mean, I think it would be hard. I have not done one recently. My 2 DVAs at the VA didn't really go well with off-the-shelf equipment. But I can tell you that I don't have as much experience. I wish Mehdi was here, but I don't think this would be a great case for DVA. I want to ask you one other provocative comment, because you did make the logic of preserving the collateral for targeting the plantar. But if your plantar access would have been in any way, I mean, that was skillfully done, anyway, not ideal, the more proximal collateral from the perineal would have been compromised.
Yeah.
So,
it's a great
I mean, that's another chance of it. But it is wonderful. I have never done this, and I know Dr. Manzi has published quite a few papers of accessing this. Can you give us some idea? Did you use the Terumo, or which needle do you actually use, and what ultrasound? Did you use the hockey stick, and what was the positioning of the foot when you were doing this?
I used the Terumo short needle. As mentioned, because the cap was so proximal to the needle, rather than trying to cross with that bare metal steel wire that comes with that short needle, we actually immediately just brought the V18 through it.
I see.
Really smart.
The V18 came up and through it, gave me that purchase. So you're essentially just navigating the CTO through the needle. I always take a minute to try to optimize setup of fluoro at 90 degrees to my axis site. So we had the foot still, thankfully, it's also someone wasn't moving too much, which is always great. We had the fluoro kind of swung to 90 degrees to demonstrate that view. We always just have a roadmap, and then I'll mark out on my roadmap on the foot exactly where that vessel's reconstituting. And then I don't remember if we had hockey stick versus just our regular kind of Phillips CX50 that we used, which gives us pretty good near field access to be able to get in. Now, not everyone's anatomy is going to be appropriate for this, but if you can find it, and you can find it on ultrasound, and you have a nice target, the fact that those collaterals were so robust, I mean, that it was filling. So we had the ability to see it on flow and get into it.
Yeah,
One other question, or go ahead, Subhash.
No, go ahead, please.
This is a great case, Peter. Very well done. The question I have, I think, more for the audience is, this area of the PT is extremely challenging because it's often extremely tortuous. And so navigating something like that, and you can see, right? I mean, you can kind of in your mind's eye make a straight line, but you have no idea whether it's making bends or not. So how do you reconcile that and navigate that, whether you're going retro or anti in this case?
Yeah. So, one of the little things is with ultrasound, when you're actually ultrasounding, ideally with that kind of good near field resolution, you try to map the course of the whatever portion you're getting into on ultrasound. So if you have just a centimeter, you're ultrasounding up and down that centimeter to make sure things are staying central in your ultrasound plane. And that even gives you the sense as to where your angle of your needle is going in to give you your purchase going straight. Now, once you get to the cap, and once you're actually entering into the CTO, you're effectively just trying to navigate a CTO by feel. And so we watch it on fluoroscopy. This was a fairly short segment CTO. We also knew where we had been from above, which gave us a little bit of insight into where we were coming from below, and we're able to navigate it fairly smoothly. Now, if that V18 had not flown, that then raises its own series of challenges, because exactly to your point, it's oftentimes can be extremely tortuous as it comes around the ankle.
Peter, that's a fabulous case. I answered a few questions on the chat for you, and one of them was to completely retrograde advance this guide wire and externalize, and then bring a microcatheter all the way down. The other option could have been to use a dual lumen 014, the new Biotronic catheter would have been. But I think this is awesome, and keep doing more of it. I think this is great.
Wonderful.
So let's move on to Samjot's case. Peter, are you good with that, buddy?
Absolutely. No, I'm looking
So Samjot, please share your case. I know I heard from Sahil personally that you have an exciting case that you guys did first time with the new device that was just FDA approved. So with your BTK scaffold. So we're excited to see it, and also share all the technical steps that you took to optimize it. So you learn from your example.
Yeah, I'm having a little trouble with it selecting the.
So just go at the bottom, share your screen.
Yeah, it's gonna share the whole screen, but then it should. Do you see it now?
Yeah, that's it. We see it now.
Yeah.
And maximize it. Yeah, perfect. You are good.
All right. I won't be able to see you, but you'll be able to see me, and that's what counts. So, thank you for allowing me to present. I'm pinch hitting for Sahil Parikh, who's the director of endovascular services at our center, and I'm sharing a case. We talked a lot about CTO crossing, but we'll be talking really more about a definitive therapy, especially in the below the knee space, and happy to share this case that's really fresh and hot off the presses. So this is a case of a multi-level CLI intervention. These are my disclosures. And the history is a 52-year-old man, ex-smoker, all the traditional coronary and pan-vascular risk factors. He has a prior right common iliac stent. He has a history of critical limb ischemia a couple of years ago when the inflow was treated, and that was sufficient to heal his wound at that time. He had an alluvia as well as supera stents placed. Then he has recurrence of CLI and both a right heel and a first toe ulcer. So he did have a pre-procedure arterial duplex. As you can see here, there's certainly spectral broadening in the SFA, but velocities are okay, suggesting that there's some disease above the level of the distal SFA. And the AT and POP, you can see certainly severely diseased with monophasic waveforms. This is a picture of the inflow. You can see the inflow is pretty reasonable. He does have that right common iliac stent that is patent. I'm going to move on to lower, and you can see here the prior stents there's an area in the distal SFA where there's a focal lesion that also looks like there's a focal ISR lesion in the proximal SFA. And then in the POP, there's also an area of stenosis here. So I'm going to use my pointer if you can see it there, right here around the canal. There's another focal lesion right down here, and then in the popliteal segment as well. Now, when we get to the tibial vessels, you can see there's a proximal severe stenosis in the anterior tibial artery, and the posterior tibial is occluded proximally, then reconstitutes off of a perineal collateral distally. So, discussion points for the panel. What would, plan B here? Would anybody consider surgery? Would you just do the femoral popliteal segments? Would you do FemPop plus AT? Would you do FemPop, AT, and PT, or some other combination? I don't know if you want to take a minute to suggest what you would do.
I think given the presentation here, it's tempting to go for the entire thing. I mean, would be my best approach here for this patient. I don't know, what do you guys think? And of course, want a lot of smart people on the audience joined in to pitch in and chime in with their responses. So what do you think, Zach and Peter?
I think you go for the whole thing. I mean, you've got multifocal disease. Most of it is not completely occlusive. It's really just that the posterior tibial, if you're going to talk about creating a CTO. So if anything, I think you have to do all of the inflow, at least do the AT, and then consider doing the PT at the end.
I agree.
Yes. Yeah. So that go ahead, Peter.
I was going to make the half joke about, a year after best CLI, we're all going to endo treat inflow plus the AT, but it's reasonable to say it out loud. I agree. I would go after all the inflow. I'd go after at least the AT, and then oftentimes in that setting, you think about multi-tibial revascularization, assuming your time on table and your contrast and everything else has been reasonable.
Yeah. So this was exactly our approach. We decided to proceed femoral popliteal plus AT, and then plus minus PT. So we're also a strong ivosite. I apologize that this isn't the full run. This is the anterior tibial artery. You can see here, I'm just going to fast forward through, and you can see here that they're really a focal stenosis with about 90 to 120 degrees of calcium, another kind of calcified segment there. Then it comes out into the popliteal. It's more fibrous disease. Unfortunately, the run sort of cuts off at the end here, but you can see this is more fibrous disease where that lesion is. And then there's a couple of areas that were fibrous multifocal ISR in the SFA. So we ended up using a Serenator balloon to cut the fibrous area in the popliteal. This was treated with a drug-coated balloon. And then when we got to similarly in the SFA segment, similarly with a Serenator followed by a DCB. And then the AT was pre-dilated with a 375 NC coronary balloon. And we can talk about some of the techniques and strategies in using bioresorbable scaffolds. And I'd be curious to see what the panel's thoughts are about using it in this context. We then did place a 3.75 by 38 BRS in the AT. Post-dilated that with a 4.0 balloon. These scaffolds can generally go up by only about 0.5. We were enrolling in the study, the Life BTK study, and for me at least personally, although I think in the study about 40% or so used intravascular imaging, but for me I think it's a must because you have to be so precise with the sizing because you can't really oversize these by more than 0.5. And then this was a final IVUS of the bioresorbable scaffold. And you can see here really a stent-like result. And it shows up quite nicely on the intravascular ultrasound. So I think that's very helpful, especially when you're not going to be able to see metal on your angio. This was our final completion angiograms.
What is the maximum length? I believe in the study you were allowed to use up to 2 or 2.5 overlapping stent, maximum of 120 millimeters, but I think each stent is how long?
So the maximum length of the stent is 38. So this was the maximum length, or I should say the scaffold was 38. So you can either abut them or have sort of minimal overlap. That's how it was done in the study. And in the study, you could actually place more than 2, but the most patients had 1, second most was 2, and then the numbers there were. I think the longest was there was 5 or 6 used in one patient.
And I didn't pay attention. I couldn't see exactly. Do the stents actually have markers, and what is the relationship of the marker to the stent edge? Is the width of the marker contained within the stent edge, or it is abuts the inner portion of the marker?
Because so you can see these are the markers here.
Okay. Yeah, and the stent is just a millimeter inside, or I can't really see, or there's a gap between the stent and the marker. Looks like there is that right?
Yeah, I believe it's just inside the marker.
Just inside the marker.
Yeah. Okay. Yeah. Okay. But like you said, I mean, it's a different paradigm, right? Because we're very used to looking at and seeing metal. And I think one of the questions is, what have we been doing for this in terms of, the role of this versus DCB, which is obviously the data is still poor, although there are newer studies, and versus a lot of us have been using coronary DES. The other thing to discuss is that in the study, you had to have a reconstitution, I believe, at the ankle or just above the ankle in terms of the vessel. So you're not treating sort of all the way into the plantars with this. Those patients were not in the study. So really, the prime candidate is a patient like this. If you try to think about the patients that were at least in the study, in terms of more proximal AT perineal or PT disease, really the proximal 2/3 of the vessel.
If you would have had a dissection that extended into the tibioperineal trunk, do the BRS platform do well when it extends past the bifurcation?
Yeah, I don't know that we know that answer.
Okay.
Certainly you're gonna run into sizing issues, right? Because the maximum that you can get is a 425. So if you're extending into the popliteal, most popliteals are going to be bigger than that potentially. So I think that's another issue. But I don't know that I personally don't know what the experience was past a bifurcation point, because most of these were placed. The TP trunk versus the PT perineal is probably where there's some experience, but I don't know the answer to that.
Understood. I think it'll be good to hear from anyone else. Peter, did you participate in the trial?
So I did not, and it's so exciting. I mean, Sanjum and Sahil on a plane somewhere. Congratulations to you guys for your leadership and Columbia's leadership in driving one of the first successful technologies we've had in clinical trial in below knee. I'm excited to get the technology in place. The thing that I've been thinking about the most is so often tibial disease is long and diffuse. To your point, Subhash, and what are we going to do? And I'm thinking about, do you do long prolonged balloon angioplasties and then use bioresorbable scaffolds in the recalcitrant areas? Because I can't imagine stacking 5 of these things in a posterior tibial in certain areas. But the kind of operations of integrating this into practice is going to be just fascinating.
Samjit, you can hit stop sharing. Hopefully it'll take you off. But a few other interesting points. I think, Zach, if you have one last case, we have just a few minutes to see it. But while you pull it up, let me ask Samjot another question. Hey,
I'll make a point too about his case if you
go
don't
ahead,
mind.
go ahead.
I think from the cases I showed to the case Peter showed, and now this, IVUS plays a huge role from everything we're talking about. We all balloon tibial vessels with, or people balloon tibial vessels with 2025 balloons, but look how big that vessel was, right?
Exactly.
And we know, at least from the coronary literature and from SFA treating inflow disease, that appropriately sized scaffolds and stenting matters. Okay, and so undersizing here, or appropriately sizing, we should say, is likely going to help lead to better patency as well, scaffold or not. I think one of my questions too was, after you guys pre-dilated that, what did it look like? And was there any dissection in the area or just recoil from the calcium? I'm just curious for my own learning too.
Yeah, so sorry, you cut out for a second. You said was there dissection post
when you after you pre-dilated the lesion before you placed the bioresorbable scaffold? Did you have was there recoil from the fibrosis? Was there dissection related to that, the 180+ degree arcs of calcium? Or there was walked away?
Yeah, I mean, I think it's a good question for Sahil, who was there, but I think personally, I think the question, I guess, now is, how much are you a believer that this is better, right? Because normally, right, all we did was tibial angioplasty. And if we didn't have too much recoil, too much of a dissection, we just left it. So I don't know that answer because I wasn't there for that. But I will say that I think I know Sahil. I know he's a believer. So I think regardless, he was gonna proceed. And I think that's the question we're all gonna have to ask ourselves, right? How much do we believe the data, and do we think it's truly superior?
Wonderful. I think this is a great case, and thanks for sharing something hot off the press. I believe you guys did this earlier today. So, and Sanjot, I know you are at a meeting yourself, and thanks for last minute filling in. Over Zach, we do have 5 more minutes. We don't want to give it up, but if you can share quickly your case, your last one, I think we can have a few more minutes of exciting discussion. Zach, you are muted, I think.
There. Can you hear me now? How about, am I good now? Yes, thumbs up.
You're good.
Okay. All right. So just another SFA case here for us. We've talked about our wire escalation. This is our typical patient who's 83. He's got known occlusive PAD. You can see his ABI here on the left, monophasic to undetectable flow. His toe pressure is 18. He's starting to have some rest pain. He's on cilostazol. He has elevation pallor here in the clinic, and that just deep rubor look to his foot. We all know where that is heading. So we brought him in for an angiogram to try to help his rest pain as well. Here's just the diagnostic from above. You can see, as an 83-year-old with disease, we know how tortuous those vessels get, right? So I think the first message of this case is, if you don't plan, you don't have good access, this case is going to be rather challenging, right? So you can see how difficult it was to get up and over here. We ended up switching over and going antegrade down his left leg because there was no hope of trying to deliver anything in a meaningful way. So here are his diagnostic angiograms on the left. He's got a prior stent in that mid SFA, and we all look at this and we say, yes, a short segment CTO, right? We can get across this no problem. But I think all of us that are on this call know that the short segment CTOs in the SFA are often the ones that haunt us the most, right? Here's his runoff, distal SFA, diffuse popcorn calcium disease. You get down into his popliteal and into the tibial vessels, and he's occluded here as well, but has significant geniculate collaterals. So this is with our antegrade approach. We've gone through our wire escalation as we discussed before. We're at the point where we have the 035 catheter and a stiff angled navicross, and I cannot penetrate through that proximal cap. So we ended up, even with our antegrade, we ended up bringing our antegrade sheath all the way down and on to through that stent just to apply more force. And eventually we we're able to break the proximal cap. And just here we are clearly extra plaque at this point in time, right? We can follow the yellow brick road, and we are not going on the yellow brick road. We are going around it. So we're going to have to get back in. We're using orthogonal views again. We try using multiple wires to penetrate that rock that's sitting on the distal vessel, but that's not going to happen. And so this is the type of case where you have to use the reentry. We have to be facile to be able to use reentry devices. So we first tried an end-tier. Okay, for those who don't know, an end-tier is like the Stingray in the peripheral. So it's a small 1 millimeter balloon that orients itself and has 2 exit ports and a very stiff wire that comes along with it. And you can see we were unable to repenetrate there, but we were trying to find a soft spot, not with IVUS on this view, because the end-tier is not used IVUS and we didn't want to make the space any larger. So angiographically, we were trying to find a spot that was not extremely calcified that we'd be able to penetrate through, but no luck there. You can see how much buckling we have. And remind you, we're pushing from only about 20 centimeters above here. So we did switch over and use a Pioneer. The Pioneer is an IVUS guided reentry device, okay? And so you bring that down over an 014 wire for those who aren't familiar with it. And then in doing so, you use ultrasound to orient towards the vessel, and then you advance a needle into the space, into the true lumen space, and then another 014 wire through that. So the middle frame here is that wire being advanced through the needle. Right down here, you can make that out, and you think we're home free now, which is great, but this device is bulky and takes some, and it takes some, if we were trying to go up and over with all that tortuosity, we would have had no chance to be able to back this device out over an 014 wire. So it's not always the right thing to use. You do get the benefit of ultrasound though while you're doing it. So then we switch out, we were able to get a Navi cross down. We know we're already extra lumen. We're likely going to be laying down scaffold at this point in time with the dissection, and we go forward, and I can show you, thankfully with aggressive ballooning, we didn't have to shockwave. We had good vessel expansion. We used overlapping alluvia stents. We were unable to get through that popliteal occlusion, but we were able to improve his rest pain and symptoms. You can see his toe pressure is now around 45. We do have, albeit monophasic, but we have signals down in his foot at this point in time. Just a couple of tips for those who haven't used Pioneer. It's a stiff device. It's a 1-to-1 torqueability, which is nice. You use the chroma flow picture, like what's down on the right. You want to orient the chroma flow of the true lumen to 12 o'clock. And then you get to choose the depth of the needle. Okay, so you want to measure on ultrasound, but I can always tell you have to advance it another 2 or 3 millimeters past what you measure. Because remember, when you push this, you're in an extra plaque space. So you are going to have some give back against the vessel. So the needle is actually not going to always advance as far as you think it will. I try to not use hydrophilic wires on this. I'm not sure what the panel's experience has been, but I have had one where it kind of has gotten stuck over command wire that has that hydrophilic tip. So if I'm going to, for the wire I'm using to go through the needle, I'm trying to use a steel core or a Sparta core wire that has no hydrophilic component to it in order to back the device in and out. So that's all I had, just another crossing device case.
Zach, leave that frame on. I think just in the last few minutes, we have seen some great demonstration from each one of you. And once again, I want to thank you all for sharing some key technical tips, because this is the mission. Our mission is that we are the operator's enclave. And I think discussing these steps of the procedure are where the successes and failures are decided. I think in this case, I think, Zach, the presence of a stent proximal to the cap actually adds a significant degree of difficulty. I mean, if the stent would have been longer or could have been mangled, you can imagine, I have a word called hostile SFA, which is a combination of occlusion, ISR, stent fracture, where you actually have to come through the stent and you cannot deform it if you have to reach the distal, the known proximal cap. So, hats off to you, and also the smart idea of bringing the sheath through the stent to get you closer and also not have any interaction with the devices. So I think those are great steps. You know, I would just say that I keep harping on Zach that anterior is my favorite device. It keeps the dissection plane small. However, this is not a case for anterior because there was so much calcium that there will
We
be
tried.
no. Yeah, you tried. He tried. He listened to me. He tried just to prove me wrong, and gives him great pleasure. But I also learned from this. But I love Pioneer. I love Outback. But I do think that bringing that guide through the stent, these are small steps during the case that can help avoid a lot of challenges. So, any comments, Peter? Parting comments from you and from Samjit?
You know, some reentry devices are a bit of a dying art. You know, we don't use them as much, and with the retrograde techniques that were discussed and some of these other options for crossing, but there are situations where there's just no better way to get across it. And so it's a great reminder. It's also, it's striking to see on the Pioneer IVUS how close you really were to the true lumen.
Yes.
Despite this rock of calcium, you might have thought you were, 10 millimeters away from the thing, but you're really just sitting right on top of it. So just well chosen and great demonstration.
No, I mean, it just goes to show it. We tried a Stato 20 and a Stato 30, and there was no penetrating back in. This is the sheath brought down. We had to bring the sheath this far just in order to break the proximal cap with the looped. I actually think I pulled the glide wire back and just used the bare Navi cross with the sheath right there in order to just penetrate. We were committing to subintimal at that point in time, as you talked about earlier. We're used to just knuckle a wire push, but I think we can be more elegant and thoughtful and keep our treatment options open if we don't always take that approach anymore.
Yeah, I think this is a really great example of reentry. And for us, I like to use either a Miracle 6 or a Confianza Pro 12 as my wire when I'm going through. So sort of a mix of what you're describing. So non-hydrophilic, but sort of a stiffer tip load. Especially if you're going through a calcified segment, that sort of worked well. But I love the device because you can see, and then you just have to make sure that you have the correct French size for this, right? So often you may need 7 French, right, for this. So that's always something.
It gets very tight. You're right, with just a 6 Frenchie. Yeah.
Peter, I couldn't resist myself from asking you in this case, because the reconstitution was slightly above the Hunter's canal and there was calcified landmark for you. Would you have stuck this retrograde and tried to put your wire up and then recapture it into the sheath up? Was this tempting enough? Is this something you would do?
Yeah, that would have been my first move. I mean,
well, I want to tell you that there is a good amount of endorsement for that approach, contrary to what I believe through the chat. So I think I'm falling behind times, all I can say. So tell me, why is that would have been your choice, and just articulate that. And Zach, if you can put up for the last.
I'm putting it up. Yep, I'm trying
your reconstitution picture. Yes, go ahead.
So a couple of reasons. The first is it's very low risk. You're sticking something that effectively is occluded. I love situations like this because, as you can see, there's kind of this double layer of filling of the distal SFA. So you've got this whole area where you could stick above the biggest collateral and get into it. The second piece is that the calcium, which is your enemy, becomes your friend. Because honestly, these cases, you're just sticking that calcium in the distal SFA. Most commonly, what I'll do in these, honestly, is I'll stick with a Cook needle. I'll put a glide wire in, and then you don't want to keep running a glide wire back and forth through the needle because you can unshear that coating. But what you can do very easily is you can take your micropuncture kit that you might have had open already because you used it for access contralaterally, and you just, once your wire is in, you take the outer portion of the micropuncture kit, slip that over your wire, and then you just try to wire cross. If your wire does happen to cross, then you can literally just use that retrograde access point purely for your wire crossing. Externalize the wire, flip a balloon over it, balloon your track, put your 6.0 balloon or whatever it is across your arteriotomy for a minute, and go on with your day. I mean, Subhash, you've done more than anyone to teach us about.
No, I have done it. I've done it for stents. Yeah. I have not done it recently. I used to do it a lot in the past. I do think that you have to a little bit prepare for it, because I used to inject that space a little bit with Lido and maybe with a droplet of contrast just to make sure that it is numbed up. I used to be mindful of not doing it in heavy set legs because it can be a problem during hemostasis. And there are a few other sticks. And I used to be honest, in stents, do it with a bigger needle and not with the micro, because there have been situations where you can have bent the needle.
I agree.
So there are some ways to screw it up if one is not mindful.
That point is key. So sticking distal SFAs, I don't do with a micropuncture needle and wire. I do it with a clip needle, introduce a glide wire, take the needle off. I use that outer portion of that micropuncture sheath just because it's the smallest possible thing that fits around a glide wire without actually making access. And then the key is to get that access site out as soon as possible and before you've reconstituted full flow. And so and Subhash, what I would say, you've taught us more than anyone about the differences in cap morphology distally versus proximally, and some of these just seemingly non-crossable cases that you've got a chance to get across.
Right.
So those are wonderful.
So Peter, do you prep the entire leg then? When you do, like, what case would you bring where you would only prep femorals and prep the foot, or in your lab, do you guys prep the entire leg for access? In our lab, we usually prep just femoral access, and if we have a feeling that we may want retro, we will have the foot prepped, but the rest of the foot is underneath the drape.
Great question. So CLTI cases, we always purely prep the foot because more likely there's multi-level disease and you're not happy if you're just fixing the SFA, you're going to want to get down into the tibial. So we tend to prep the foot and go just with tibials. If we have kind of pre-procedure good arterial duplex showing us an SFA occlusion, we'll prep that frog-legged kind of inner thigh overlying the SFA. And I'm also not averse to having someone climb under a table in an uncrossable SFA and scrub up the thigh and then cut a hole in a drape.
Yeah, I think you can generally, what I used to do is to have a prior angiogram, Zach, and then prep the medial part widely and then cover it up with another piece of drape so that it is left outside. You can remove it and go on doing. But I think it has become less frequent these days. But I think these are wonderful ways and techniques and that you all have demonstrated. I thank you, Zach and Peter and Sanjum, and for showing and especially sharing some of the technical know-hows and decision points in a case, which I think are going to help us. And again, I think our training as interventional cardiologists has a lot to do with it. And I do think that the role of imaging is only growing as we continue to embark and treat below the knee and above the knee occlusions. My final word for today is that a person who is doing coronary CTOs can choose to be a CTO operator or a non-CTO operator for peripheral interventionalists because 40% of lesions are occluded. It is obligatory to know how to deal with CTOs. So I hope for that reason alone, this engaging and hopefully useful conversation will be remembered and commented upon by our participants who have been very active on the chat. I've been answering for you, but also passed on all the endorsements for each one of your techniques that came to the chat line. So once again, thank you all very much and have a pleasant evening. And Kelly, if you can show the last slide in terms of the CME registration. While I show you that on the screen and also maybe the code, the QR code to scan, I once again want to thank our faculty members, especially today, Zach, Rosol, Peter Monteleone, and Sanjum for joining in today and making this discussion so lively and so very valuable. So here is the link and the QR code to complete and download the certificate and get your CME. And so we will see you all, hopefully, and not hopefully, but surely at CVI 2024. Remember, our conversations are going to be around technical skills and devices, something that you can get anywhere else, but can get a deep dive in Denver. And these fine gentlemen and ladies who are participants in today's webinar as faculty and as participants and who joined the webinar today are all going to be there. So once again, thank you very, very much. And till then, bid farewell and goodbye and have a great evening.